On this episode of the Athletic Potential Podcast, we will be discussing the key aspects of a successful knee surgery rehabilitation, as well as our recommendations for in-season weight training for our softball athletes. Welcome to the Athletic Potential Podcast, your place to come and get answers to your athletic development questions. We cover a range of topics, all related to helping you to achieve your athletic goals so that you can experience and enjoy the athletic career that you deserve. I am your host, Dr. Mike Matthews. Hey everybody, and welcome back to the Athletic Potential Podcast. Excited for this week's episode, excited to have you back. And I just finished having, well, I shouldn't say just, it happened yesterday, but I just had this great discussion with, I have a full-time student right now. His name's John. He's fantastic. He's a great student. And one of the benefits of having a student as a clinician myself is that it kind of comes into challenge all of my current treatment philosophies and how we use, like why I treat certain things the way I do, or train people, or training programs the way I do. And it's always fun as for me to be able to obviously teach, but at the same time to make sure that all of my programs and everything that I'm doing is really what I think they're doing, what I think they're actually doing. And so in order to make sure of that, I have to teach it. And when I teach it, John has to internalize it and see if it works. And I kind of have to justify everything I'm doing. And I think it's a fun experiment. Now, one of the reasons I bring this up, and I'll be honest, it's a little bit of a personal vein right now, mainly just because I want it essentially documented, but it's a kind of a fun concept. One of the things that I spend a lot of time doing with all of our clients, more specifically those in the rehab side that have injuries and we're trying to progress them back. But one of the things that we do all the time is we try to stage injury. So we essentially say, okay, you damaged something, tissue, muscle, whatever. And as a rehab specialist, like our job is to say, okay, well, where is this tissue at in the phases of healing so that I can do two things. One, I can make sure that the environment is exactly what it needs to be. When I say environment, that's like hydration, nutrition, activity, modalities, heat, ice, that kind of stuff. By the way, I don't know when I said ice, but you know what I mean, that kind of thing. And is the environment optimized for a healing response? And then the second thing is, are we doing the appropriate things to then enhance that healing response that's not included in the environment? That would essentially mean loading. Are we loading? Are we stressing the tissue in a way that's going to enhance healing to allow for whatever tissue that's been damaged to heal well and then stronger than it was previously? And so this is something that we're doing constantly. And so John and I have a great discussion yesterday about this, of the framework of how do I stage an injury with clients. And it's something that I do all the time. I've never put it into a format, and we kind of put it in a nice little format. And I'll be honest, I think it's going to change. But I wanted to talk about that format. So, and it'll come into play in our first question. But I want to talk about it first. So when we talk about staging an injury, and you can do this on your own too. You don't have to be a rehab clinician to think about this. But the first thing we always do to stage an injury is we talk about pain. What's your pain levels? And I get it. I'm sure there's colleagues out there that are just like, yeah, pain is not, there's so many issues with just using pain. And the answer is, we're not just going to use pain, but it's where we start. So pain. I always ask, hey, how much pain are you in right now at rest? And they usually give me an answer. I'll be honest, if that answer is anything 4 or above, I don't do anything else in the treatment session until that pain is 3 and less, or 3 or less. And so I usually ask about pain. And if they're like, oh, I'm like a 3 or less, or I'm like a 1 at rest, and I say, well, what about, when you're doing activities, when you're moving, just generally, how do you feel? It's still a 1. I'm like, okay, great. So first of all, we know that the tissue is not irritated and painful, and we know that the body's not going to be in a majorly guarded state at that point because the pain levels aren't very high. those type of things. So that's the first thing. So first thing is always asking about pain and make sure pain is 3 or less. If pain is 3 or less, then we move to the second part, and that is we're going to stress test the tissue in question. Now, hang with me here. When we stress test, this is very, very controlled. From a rehab clinician standpoint, this is what we're trained to do. We're trained to know how to stress tissues to make sure it's a certain tissue versus not another tissue. We know how to test these things well, and we know how to test these things well enough that we won't recreate an injury. And that's the key. So we're going to stress test the tissue. That usually involves some sort of resistance. So imagine me like having somebody push against something if it's their shoulder, having them go through a full range of motion in their shoulder, elbow, have them essentially just move through range of motion in their knee, those type of things. That's kind of the stress test. Now, the other thing that we always do is then we use our hands and we start poking and prodding and moving stuff around to see if we can irritate the tissue. I should be giving you an example, and I apologize. And maybe what I'll do is I'll finish the format and I'll go through a quick example of somebody we used this with yesterday. Okay, so the first phase is what's your pain level? 3 or 10 or less is the goal. If that's the case, then we're going to stress test this tissue. So we're going to use our hands. We're going to move it around. We're going to poke it. We're going to have them go through range of motion. We're going to do light resistance in a very controlled manner. If the stress test comes back fairly negative, meaning that you couldn't really stress the tissue enough to produce pain or produce other signs of pathology, now we're going to go field test it. And field test basically means we're going to go take them through activities, movements, something that mimics more of what the activities they're trying to get back into. This could be squatting. This could be overhead lifting. This could be carrying. This could be rotational, like quick rotations, and think about swinging and hitting, throwing med balls. We're going to go out and do a field test to see if they can do the movements without aggravating that tissue. And the field test all depends on, again, if they're able to go out and do a bunch of these activities and have no pain and no problem, we know when the injury started, we can make good decisions on how much we should be loading or how much activity we're allowing these clients to go through. So to give you an example, we had a client come in yesterday. He's been dealing with right little leaguer's elbow. It's essentially an irritation to the growth plate in the elbow. And it's essentially a bone problem. So we know we've got to give it time to heal. But if we load it the right way, we're going to see improvements in his ability to heal, and it's going to come back stronger than ever before. And so when he came in, I believe he was at a 6-week mark following little leaguer's elbow. He came in and we asked some questions, and I said, "Hey, are you experiencing pain in your elbow?" Okay. Deep down, I was like, man, he better not have any pain in his elbow because we're 6 weeks into this. Pain should have been gone at like 3 to 4 weeks. Good news, he had no pain. So he comes in and says, I don't have any pain. I'm like, well, what have you been doing? He's been doing some exercise that I gave him from last time. He's been doing basic activities at home. He's not throwing. He's not hitting, any of those kind of things. Okay. And he says, look, I don't have any pain with any of the activities. I said, okay, great. So on the framework, we're less than 3 on a 10, right? So it's 0 out of 10. Great. Let's move on to stress testing. So then what we did is we had him go through range of motion. We did passive and active range of motion. We stressed the elbow in every position that we could think of that would potentially put stress through that growth plate. And then we poked, prodded, and used our hands to see if we can make it irritated. And lo and behold, he had mild tenderness, but by the way, if you push hard enough, anybody's growth plate probably won't feel very good. And he had mild tenderness, but nothing that was outstanding. So we tested for pain, all clear. We stress tested it, all clear next. So the next part of this was, great, let's go field test this. So at this point, we know his activity that he's trying to return to is throwing. So I said, look, we're going to go throw something. So we picked up 2 different plyo balls, a 5-ounce plyo ball, which is the same weight as baseball, and we picked up a 7.5-ounce plyo ball. And I told him, look, we're going to go throw these against the wall. We're going to do it roughly 10 to 20 times, and we're going to see how you do. He threw 20 times, 10 with the 7.5 and 10 with the 5-ounce. First part of the field test, completely pain-free, no problems. Hallelujah. So we went to the next phase of the field test. Is a lot of times these clients will have issues with prolonged throwing. Volume is a problem. And so what we did is we switched away from the plyo balls and gave him a football. I believe it turned out to be a pee-wee football, but we really wanted it to be a full-size football. Either way, it's going to weigh around a pound or so. And we had him throw that for anywhere 8 to 10 minutes. And that's our field test. He came back in. He complained of no pain during the field test. I went one step further, went backwards in the protocol, and I said, great, I'm going to poke at this thing and see if it's irritated to touch and other things, but maybe not to the throwing motion. Tested it again, no problem. And so guess what we did? We graduated throwing a football anywhere from 5 to 8 minutes per day. We're on a progressive return to throwing at this point, and the hope is that in a week, he's going to demonstrate continued no pain and no problems with the throwing of the football. We're going to introduce hitting after 1 week. After the 1 week of hitting, after another week of full hitting and full throwing of the football, if he still has no symptoms, he gets to pick up a baseball and go through an interval throwing program. And that's how we can use this to stage injuries and then make good decisions clinically to get people back to their activities. And it was just a great discussion that John and I had, and I wanted to share it in the podcast. So for those that have gone through injuries and those type of things, just understand that knowing at what phase of the injury, of what phase of healing the injury is at, is really critical. And it's a decision that a lot of times, I'll be honest, even clinicians don't take a lot of time. They just go, oh, it's been 6 weeks, you're good to go. And the answer is, well, hold on. Like 6 weeks is the average. There are people that get better than 3 weeks, and there are people that get better than in 9 weeks. We got to make sure that this person is actually getting better. And so it's something I want to share in the podcast, something I know I've got a few clinicians that listen to the podcast. It's always kind of fun to be able to take what we already do on a daily basis and really give it a format and a framework, because I think from here we're going to be able to go forward and make better decisions and improve this, and maybe even be able to start really making fine-tuned adjustments to allow us to make very, very good clinical decisions without having to guess a whole lot. So hopefully that's the case. So all right, let's jump into this podcast episode now. We're going to go, we've got a couple questions here. The first one comes from John, and lo and behold, it has a lot to do with everything we just talked about. And here we go. So John says, what are your recommendations for someone who just had total knee surgery? Now, when we talk about total knee surgery, if those don't know what it is, what happens is it's typically a surgery that's done 55 and older. What happens is the cartilage in the knee on both sides, so where the knee hinges, those are see it on the video, you can see my hands, there's cartilage coating one side and cartilage coating the other side. What happens is that cartilage eventually breaks down to the point where you have no cartilage and you get bone on bone grinding. It's nasty, it hurts, it's no fun for anybody who has it. And so what happens is there's a surgery where they go in and they essentially take the bone off one side, pick the bone off the other side of the joint, put an implant on one side, implant on the other. It's usually metal or some sort of composite material. And those joint surfaces now are metal on metal or total joint surgery, because the joint is now different. Now, it takes the pain away. That's good news. It allows people to move better. That's even better news. And so these things are good. They're also very difficult to rehab at times based on a lot of different complications, which brings us to John's question. What are your recommendations for someone who just had total knee surgery? What do you feel are the most important aspects of the rehab to make sure someone returns to full activity participation? John, this is great. In my practice prior to coming to Athletic Potential, I worked for right around 10 years in an outpatient orthopedic setting, and I have done a lot of total knee rehabilitation. This is something that's seen day in and day out in every orthopedic clinic. And you'd think we'd have a really good handle on exactly what should be done after these total knees. And the answer is we really don't have a great handle on it. But I do have some key things that I teach all my students that I have found have made the rehab for these patients very, very successful. And it seems that they haven't changed a whole lot, and they're pretty basic. Okay. So, John, I think the best way to answer this question is what are the top complications of this surgery? If you get rid of infection, meaning we don't use infection and we just assume that you won't be infected. Okay. Which is a whole other thing. Okay. It's a big thing, but we're not going to talk about it. Okay. Assuming you don't get an infection, the number one complication following a total knee surgery is a lack of return of full mobility of the knee, meaning you can't bend or extend it as normal. Okay. Now I can tell you this, that lack of flexion of the knee is a problem, but not nearly as bad as extension. If you do not get full extension of your knee, you will not walk normal. You will walk with a limp or an altered walking pattern. And so I prioritize range of motion heavily. Now, before we get too crazy into this, I can tell you the first thing I prioritize is pain. And the reason I brought up one of the biggest complications is lack of range of motion is one of the biggest predictors of someone not achieving their full range of motion and developing what we call an a fibrotic knee. My apologies. A fibrotic knee is high levels of pain over a long period of time. They seem to get more scarring. And what happens is that scar then kind of surrounds the joint. It's not really what happens, but we'll just say that because it's easier to visualize. Surrounds the joint, limits its ability to extend and flex, and you get more pain. And that's no fun. Okay, so the number one thing I prioritize following surgery, specifically total knee, but really any knee surgery, is pain. If your pain levels are 4 or more, your entire goal is to get your pain levels 3 or less. I don't care. You don't work mobility. You don't do. What happens is you have these surgeries and they come out of surgery and the doctor's aide or the nurse or even the physical therapist that's there in the hospital with you goes, hey, look, here's a list of exercises. You need to go do these anywhere from 1 to 3 times a day. Go. And the problem is they tell you that, but then a lot of times what is not conveyed or not conveyed very clearly is that you need to do these exercises in 3 or less pain at all times. And a lot of people's like, no. Like, I need them to move. And I know there's doctors out there that say that. And I get it. But it is really these patients that are trying to push through pain 5, 6, 7 and try to get range of motion. And my experience, and I've got some research to back this up, is that those range of motions don't seem to come very easily or they don't stay very well. Meaning you may get it, but you have to pay for it the entire time you get it. And the next time I see them, the range of motion's back to what it was before, and it just didn't stick. And so, John, number one, pain. Pain needs to be 3 or less. As soon as you can possibly do that. You do whatever you got to do to get the pain levels down. That could be medication, if the doctor's prescribed it. That could mean heat. By the way, I don't typically heat over the top of a brand new surgical knee just because of the incision. I'm not a fan of that. Okay. It could be heat, but I'd heat the thigh and those kind of things. That could be, here we go. It could be ice. Ice is effective at reducing pain. Okay. So you could use ice. It's not my first go-to by any means, but you could. Whatever you got to do to get the pain levels down. Okay. 3 or 10 or less. Now, if your pain levels are 3 or 10, 3 of 10 or less, great. You can move to phase 2 of this, which is at this point, you're trying to get your knee completely straight. And you want to do this as soon as possible. Okay. As soon as possible. What I found is if we can get it early and get it quickly, we won't have to fight to get it later. Now, my mother had both of her knees done. One of the things that we did, she had surgery. She went into surgery. She came out of surgery. She went back up to her room. She was resting. I came in. I had to work that day. But anyways, I came in right after as soon as I was done with work because she was still recovering from surgery. Came back in. And I talked to her. And she says, look, my pain level is like a 5 or a 6. I said, great. So your pain level needs to get down to a 3. We did that through medication and some positioning and those kind of things, which helped a lot. And then once we were able to do that, and it was consistent, meaning like 30 minutes to an hour, I started having her straighten her knee. Okay. Her knee's completely bandaged up. It doesn't matter. We were starting to straighten her knee in the hospital bed, in the hospital before she was discharged. And I could tell you, we did that for both of my mom's knees. We did that immediately and we did it very consistently. And she has 0 problems getting extension of her knees. 0. And to be honest, I don't think we had an issue getting her knees straight past day 3 of surgery. And so not that that's like, woohoo, look at me. But the idea is like, realistically, we got full knee extension, 0 flat knee, right? Flat, out straight within 3 days. And I never had to fight it again. Now I worked it, made sure it got straight every time I saw her. But I can tell you that the clients that come to me 5, 6 weeks out of surgery that have been working bending and straightening, but they're lacking extension, I will spend the next 2 to 3, maybe 4 visits just trying to get them extended. And I'll tell them to stop bending their knee. And you know what happens? Their knees finally get straight. We don't really lose hardly any bend. Their pain levels go down. So, John, pain, 3 of 10 or less. The second part of this is get your knee completely straight as soon as you possibly can. Okay, as soon as you possibly can. Again, this doesn't just apply to total knee patients. This is I did the same protocol with a client of ours that just had an ACL reconstruction. Okay. So that, and then the phase 3 of this is that I need your muscle, your quad, the muscle on top of your thigh. I need it to actually fire, flex, and do its job as soon as possible. We found if we can get those things back quickly, we seem to have a much easier road in regards to rehab, and we typically get back to all activities. It's those that really have a hard time firing their quad, which happens after surgery. It's a grind. It's something that we've gotten better with. I got better with. I actually have technology now that helps me with this with clients because it becomes a problem. And if you can get that quad to fire and do so well, we just seem to have less issues. So John, there's a lot more aspects, but let me just recap what I think. These are the 3 most important things. These are what I work on with my clients. And if I don't have these 3 things, I don't worry about a thing until I get these 3 things going. Okay, ready? Pain, less 3 or 10 of less or less. I don't know why I can't say that today, guys, but I can't. Pain, 3 of 10 or less. Second thing is I want that knee completely straight as soon as possible. Okay. And the third thing is I want the quad to actually be firing and showing good ability to contract as soon as possible. Okay. Those 3 things, I think if you get those 3 things, you're going to see good results down the road and getting you back to everything you want to be able to do. So hope that helps, John. All right, let's jump to our next question. This one comes from Paul. What are your recommendations for weightlifting in season for softball athletes? How often, how heavy, etc.? Paul, this is a great question. This is something that obviously we're transitioning to here at Athletic Potential right now. We're coming out of the off season and into in season, and our athletes are starting to ramp up and start playing games and participate in their sports. This is a conversation I've had a lot lately, and I can tell you this. Let's get very specific to softball because I can tell you it's way different for baseball, and it depends on the level of softball. If we're talking about youth athletes, I really like the youth athletes to continue to work out. If they're in a if they're in the habit of going to the gym or going to somewhere to do workouts, I think it's a great idea to continue that habit. Now, we may decrease it. So if they're coming in 4 to 5 times a week, which happens, I may decrease it to 2 to 3 times a week. Because I think the youth athletes, when I say youth, let's just say 11, 12, 13, 14, 15, those ones. Okay. I really like those guys to keep coming back in and those girls to keep coming back in and training, because I think there's things that will continue to happen and they'll continue to improve. I think we can not get them sore. I can make sure that they're not tired at the right times with good timing and tournaments and games and stuff like that. I think we can do that. So Paul, to answer your question, I really want my youth athletes to continue to train 2 to 3 times a week, preferably on site. And the reason is because it's a lot better to have them here, to see them move, to be able to cue them, to coach them, and to make sure that they're being very consistent. Okay. Now let's talk about our 16, 17, 18. So these are our high school athletes that are harder. I like to have my high school athletes, specifically the softballers, twice a week. I want them back in the weight room. Okay. Now I'll switch the weight room training around. And this is part of your questions of like how often, how heavy. Twice a week. Okay. And I want them to make sure that they're maintaining strength and power. So what this looks like is they're going to have essentially 2 lifts that are power lifts. They're going to have 2 lifts that are more strength lifts. They're going to have 1 carry lift where they just pick up weight and carry it. That's it. They're done. They don't have to do any more than that. These weight training sessions, in my opinion, for the softballers should be 30 minutes, 40 minutes maximum. Okay. And all we're trying to do is have them get to their strengths. Now, I know you're going to ask this question, so I'm going to try and give it to you. Okay. We got 2 power movements and 2 strength movements. Okay. What I like to see in regards to the strength movements is I want to see them hinge. This is a deadlift. Think deadlift. Okay. I want to see them deadlift. Okay. And I want to see them, squat. Okay. Now I'll be honest. I don't prioritize the squat. I don't. I want to see them hinge and I want to see them squat, but I'll tell you on the squat side, I usually tell them to go lighter than they normally would. Because I don't see the girls don't need to squat. It just doesn't seem to translate very well. Okay. I want them to hinge. Okay. I want them to squat. The 2 power movements, pretty straightforward. They're going to do some form of jumping. Um, I, um, we've done trap bar deadlift jumps, those type of things with our athletes here. Weighted vest jumping with good landing skills. We like to do that. Broad jumps pretty much is like a given. We always do broad jumps. I'm not a big fan of box jumps. I don't like that. So those are the 2. So some sort of jumping, usually a weighted jump and then an unweighted jump. So sorry, this is getting kind of vague and I apologize, but think broad jump and then like a trap bar jump or resisted against bands or something like that. So there's a little resistance to the jump. So we've got hinge, squat, broad jump, some sort of resisted jump, usually vertical, and a carry. Carry is quite simple. Pick up a weight, carry it a distance, bring it back, do it maybe once or twice, done. Okay. Now, a lot of people are going to ask the question, I didn't say anything about upper body. You are correct. We are talking about throwing athletes here. Throwing athletes. This is where it gets tricky. And I can tell you right now that most of my throwing athletes, and I'll specifically go after softballers, okay, Paul, is at some point in that same week, we are doing 2 sets of 5 of an inverted row. That's where imagine you got gymnastics rings hanging down from a rack. You stick your feet out on top of a box. So your body is starting in either a flat position or slightly declined. So your arms are hanging onto the rings, your feet are on a box. Then they're going to do a row, pulling your chest up to the rings and then back down. You're going to do 2 sets of 5. Okay. I really like that. It's simple. It's not very hard on the joints. It gets that nice pulling strength, a lot of core strength or core coordination with it as well. I like that. So I'll be honest. I didn't mention that in the 4 lifts. You're right. But I'll be honest. Most all of our softball athletes are doing that. Now, the next thing you've got to be a little bit judicious with this is this. I still like them doing pressing motions. Okay. We know for anybody that follows my work, you understand that I like certain movements. Hinge, squat, push, pull, carry. Okay. Done. Thank you, Dan John. Moving on. Okay. So I want to see those in every lift, but I'm prioritizing because let's be honest, we're in season. Sometimes these girls are only going to get 20 minutes to work out. Okay. College setting, they maybe get more, but to be honest, college setting, they may get tons less because they may be on the road. The softball team that's here and close to us was just on the road for 15 days. 15 days. They're getting workouts in like hotel gyms, which is not that they have nothing. You know what I mean? So anyways, the point is this. I'm trying to prioritize lifts because if I have a softballer who needs to go get a lift, I'm going to go, look, here's your priorities. Hit these first in this order. And when you run out of time, just leave the gym and you'll be fine. And so let me be very clear. I want them to hinge, 2 sets of 5. I want them to squat, like maybe 1 set of 5. So 1 set of 5. I want them to do a broad jump, 2 sets of 5. I want them to do some sort of resisted vertical jump, so band resisted, trap bar deadlift, whatever, 1 set of 5. Carry, 1 set of 20 yards on each hand. Okay. Now, if they've done those, great. I'm going to have them go 2 sets of 5 of inverted rows or rows, and then we're going to do another 2 set of 5 of presses. That can be push-ups, or if someone's done a lot of work and their shoulders done, like if it's a pitcher, they're going to do 2 sets of 5 non-throwing arm presses, and to give the throwing arm a rest. Okay. Sorry, Paul, we're getting kind of into the weeds on this. I wish there was an easy way to put this, but this is in-season training. The key is that the strength measures that we've developed over the course of the off season, they need to be maintained. And if you don't lift, they're not maintained. And there's problems with that. Okay. We see decrease in our athletes' durability, or mainly, if you want to say durability, we see increase in our injury risk for those athletes that lose strength over the course of the season. That's anecdotal research and backed by some of the research that I've seen. Okay. So I really want to see the strength numbers maintained. Okay. But you got to understand, you have to prioritize field performance over gym performance. And we got to tell our softballers this too. Look, I don't care really, like I don't want you to be a hero in the gym. I want you to be a hero on the field. So look, you go in, you get your work done in the gym, and you get out. That's your job. You should leave the gym feeling good, not tired. Good, not tired. Okay? Those are some of the core principles that we usually follow. By the way, I also don't give any new lifts to any of our athletes that are in season. I don't want to add anything new, because guess what happens if you do something new? You typically get sore. And I can tell you right now, a lot of our athletes do not like to be sore when they're trying to perform. I mean, I don't. And I'm not saying I'm the end all be all, but come on. If you're sore and you're trying to throw a baseball, 60 feet 6 inches at high velocity so it doesn't get hit 400 feet by the guy on the other end, I don't really want to be limited because I'm sore, right? I want to feel good. So, Paul, let me bring it all back into a nice little package here for you. Okay. In-season lifts should be done twice a week. They need to be done in essentially this order. I want to see 2 sets of 5 of a hinge, see 1 set of 5 of a squat, 2 sets of 5 of a broad jump, 1 set of 5 of some sort of resisted vertical jump. Okay. 1 set of 20 yards in each hand of a carry, 2 sets of 5 of inverted row, 2 sets of 5 of a push-up or a single arm dumbbell press. I think if you just followed that, you'd be just fine. I think your athletes would be in good shape for the whole course of their in-season. I will tell you this, our professional athletes are doing more than that. But realistically, not a ton more, but they're doing more than that. Our high school athletes typically do a little less than that. But you got to understand, our professionals, specifically we'll say baseball players, these are pitchers. If they're pitchers, they're thrown, once so many days. They're not really sure if they're relievers. If they're starters, they know exactly when they're thrown. And so they have the ability to lift heavier and harder because they have a better idea of when they're going to pitch. If you're in high school and you're a softballer or a baseball player, you're more than likely playing a different position when you're not pitching. Right? If you're a JV guy, or heck, if you're a sophomore, you're probably potentially playing in a sophomore game. You're then playing in a JV game, and then you might even play in a varsity game. You have no idea. Get 2 lifts in a week. Do your best to try to hit it in that order I gave you, and I think you'll see good results. Okay. So, Paul, I hope it answers your question. The softballers, I gave you the specifics for the softballers. Baseball players, I changed a little bit, only because I feel like we need to hit a few more things for the baseball side of things because of field size and a couple other things. Okay. So anyways, Paul, I appreciate the question. And that does it. That does it for this episode. We had 2 good questions. We had a nice little rant in the beginning for me just because I wanted to talk about it. It's something that I think it's a good thing. It's to stage an injury is one of the more difficult things we do. But I think if we can do that very accurately and effectively, then we can get our athletes back and to playing a lot faster. So appreciate the questions by John and Paul today. I appreciate the questions by everybody that if you've asked a question on this podcast, I appreciate reaching out. We appreciate being able to answer these questions. I appreciate you listening and the trust that you put in us and hopefully giving you good information. And please reach out with any questions you do have. Talk to anybody that may have questions. Tell them about the podcast, have them ask questions. And we'll get all their questions answered. And I appreciate the time. Rate and review on Apple Podcasts for us, and tell your friends. And until next time, thanks.
Hey everybody, I just want to say thank you for listening to the Athletic Potential Podcast. If you do have questions for the podcast, please visit the website www.athletic-potential.com/podcast. You'll find a button there to ask your question. Please input your information and your question, and we will answer any and all questions we get. We thank you again for listening. If you do get a chance, please rate and review the podcast. And until next time, thanks.